Jehad Ahmed. He's a consultant neurosurgery and spine surgeon. He will present us the first talk. Please, the stage is yours.
Okay, thank you so much. Assalamu alaikum. So, I'm going to talk about Atlantoaxial rotatory subluxation in adult. So, going to go through the introduction, anatomy and biomechanics, clinical presentation, classification and radiological images, management principles, and then we'll show some practical cases and home message. Introduction: rotatory subluxation of C1 over C2 is a rare condition, especially in adult and traumatic one. Infection is the most common cause in pediatrics, while adult trauma, rheumatoid arthritis are the common causes. So rotatory subluxation, it could be pure rotation if the transfer ligament and adenoid are intact, or it could be associated with anterior or posterior subluxation. So this is just brief review of the anatomy of C1. As you can see, this is the inferior articular facet of C1. It's pointed medially and inferior. It articulates with the superior articular process of C2, which is pointed upward and laterally. Together, they form the lateral atlantoaxial joint. As you can see it here, it's somehow concave to allow the movement in different directions. And the other joint is the median joint between the odontoid transfer ligament from the back and anterior arch from front. These are the ligaments related to craniocervical and C1, C2 complex anatomy. The most important is transfer ligament and beard error ligaments. Biomechanics, as we all know, the C1, C2 is responsible for up to 60% of head rotation. But it does also small function in flexion, extension, and translation, anterior, posterior, and left to right. The motion is limited by the transfer ligament from the back and odontoid from the front. So if there is any defect in any of these, you will have subluxation with possible rotation. There are many classification systems. The most commonly used is Fielding and Hawkins classification. It's classified into 4 types, simply based on which joint is subluxed, unilateral, bilateral, and whether the transfer ligament is intact and the adenoid is fractured. But not all rotatory subluxation will fit this classification. There are some cases you cannot classify it based on this, and we'll come to show it in the practical cases. So clinically, patient with rotatory subluxation, typically they present with history of trauma, RTA, fall down, and they have muscle spasm, neck pain, and torticollis. You will never, you will never see a rotatory subluxation without torticollis. So some of them, they might have vertebrobasilar insufficiencies if there is compression or dissection of the vertebral artery. Radiology, as you can see, the usual finding is a head rotation to one side, while the rest of the spine to the other side. You might see associated fractures or anterior or posterior subluxations. CT and CTA, mandatory in these cases. You will see the coronal, sagittal, and axial. You can see here the subluxation with rotation of C1 over C2. MRI is essential to evaluate the spinal cord injury and the ligamentous complex. If you see here, there are like some hyperintensity that indicates possible ligaments injury. Treatment. So generally speaking, treatment is the principle or the objective is reduction and immobilization. The infectious cases, Gressler syndrome, usually treated by conservative close reduction with Halovis or C-collar, while the traumatic one, it has a different strategy of treatment. Usually traumatic rotatory subluxation associated with other kind of trauma, odontoid fracture, facet fracture. So most of them, they end up with surgery. Still the principle of reduction, either closed or open intra-op, with the open mobilization or fixation by C1, C2 posterior fixation. C1, C2 posterior fixation are typically nowadays we do polyaxial screws of C1 lateral mass, C2 bars or pedicle. The other options, which is like for history, Galley fusions, Brox and Inks fusion, Sontag, transarticular, were described before. The C1, C2 posterior fixation, this is a usual entry. The first time described by Dr. Guel in 1994, and then modified by Harms in 1997. And since that time, we are using the modified technique. This is briefly the insertion and trajectory of C1 lateral mass, and this is the C2 bars and pedicle screws. And these are the other techniques that are usually used. We have, I mean, it was used before, but now usually if we use it like the wiring as supplementary for the polyaxial screw fixation. Whenever you are talking about C1, C2 surgery, you have to pay attention for vertebral artery, and especially the high riding vert, which is the most common anatomical variation that you might find it. Now I will go to the practical cases. So this is case one. This is a 20 years old male patient, RTA. He went to a peripheral hospital after the accident, complaining of neck pain. They missed his diagnosis. They just give him a collar and refer him to a tertiary hospital. He landed in our hospital after 3 weeks with neck pain and torticollis. He was holding his neck to elevate his pain. So he was admitted. This is his CT. As you can see, with the mid-sagittal view, there is odontoid fracture. It's type 2. And if you look carefully to the facet, you can see subluxation. It's not a complete, it's just partial. And then, if you go to the coronal, you will see how bad it's subluxed and the rotation. So whenever you have clinical symptoms, subluxed facet with rotation, this is rotatory subluxation. It's not going to be positional, because if you see the C-spine, the odontoid is central while the head is tilted. And on axial, there is clear rotation. And on coronal, there is unilateral subluxation. This is a 3D. You can appreciate the subluxation there. So in this case, there is, as I said, it's surgical, because you cannot treat this patient conservative with odontoid fracture and subluxation. So intraoperative reduction with neuromonitoring. And again, we do, while the patient's supine, we do baseline neuromonitoring, and then we flip him, we do another baseline neuromonitoring. We make sure it's reduced, and then this is pre-op MRI, and this is a post-op. Case 2, again, 25 years old, smoker, RTA. He was seen in in his hometown. And after 6 weeks, they actually diagnosed him with odontoid fracture. They offered him surgery, refused. They put him in a collar, and he missed follow-up. He came to our clinic after 6 weeks. Again, neck pain and torticollis. This is X-ray. So obviously the C1, C2 is not normal. There is some sort of pathology. So we did the CT. I apologize, I didn't have the sagittal cuts. So as you can see, the C1 is rotated over C2, clearly. And if you go back to the X-ray, there is anterior subluxation too. While the ADI is normal, because the tal is not injured. So this subluxation is because of odontoid fracture. That's why they have subluxation anterior with rotation, while the ADI is normal. So again, positioning, baseline neuromonitoring, intraoperative, post-positioning neuromonitoring. If we have the O-arm, we like to use it because it allows to do a better screws. And you can see he's reduced. And you can do bicortical screws if you have the O-arm, and to help you in reduction and to maintain the stability. This CT actually is 3 months post-op. It's aligned and fused. So the message from these two cases the initial presentation is odontoid fracture. But it's more than odontoid fracture. If you look for the facet carefully, you will see either a stable facet, and this is pure odontoid fracture, or you see like cases like what I showed, there is like rotation or anterior subluxation, posterior, or combination of both. And ADI doesn't have to be abnormal because in these cases, the subluxation because of bony fracture rather than transfer ligament injury. So the last case is the most difficult one. This is a type 4 rotatory subluxation, which is extremely rare. She is around 78 years old lady. She had just osteoporotic, small fall, and she has some neck pain that was getting worse over 2 weeks. When we saw her, the pain was so severe and her head was tilted. Are you gonna see in the x-rays? This is her head position. And this is the CT. So if you look for the CT, there is odontoid fracture, there is rotatory subluxation, and if you go further, the C1 facet is subluxed posteriorly. So posterior rotatory subluxation. This is the corona, and this is the 3D. This is the front. You can see the C1 is completely subluxed backward with rotation. This is like not reducible. We tried to reduce it pre-op, did not work. Then she was high-risk patient with cardiac issues. We have to reduce it intra-op. We took the patient. This is the MRI. So again, we did positioning and neuromonitoring pre and post, and this is after reduction intra-op, and this is pre-reduction. We started the procedure. We did one side. Then the anesthesiologist told us the patient is unstable. They don't know what's going on. We had lost maybe around 700 ml blood because of venous congestions. Then we had to abort the procedure. She went to the ICU, and day 2, she developed a picture of DIC, and we could not save her. It was a challenging case, comorbid, and maybe in the future, such case, if I could reduce it without going for surgery, I will do it, because these patients, they do not tolerate such big surgeries. So, in conclusion, home message, craniocervical junction C1, C2 anatomy is very complex. You have to get oriented to the anatomy of each individual case. Definitely, if you look carefully for the images, you will find something different between cases. C1, C2 rotatory subluxation is rare, so you have to keep high index of suspicion, and you have to look for it. I mean, if you have odontoid fracture, you have to look for possibility of C1, C2 subluxation, anterior, posterior, rotatory combination, and use technology. If you have neuromonitoring, actually now neuromonitoring is a must. If you don't have it, refer it to someone who has the facility. Better to do it with O-arm if you have it. All this will increase the patient safety and you do a better job. I think I'm done. Thank you so much.